sense of the pathogenesis of hypertension through various pathways. So I think we should make the blue a lot bigger, but maybe this is just the artistic license. So how is the putative pathogenesis? So we have DNA sequence variations and various pathways leads to abnormal gene regulation or change gene regulation leading to the phenotype of hypertension. Or we can have the environment acting through epigenetic factors which change the stimulation or switching off of certain genes and can lead to the phenotype. So there are a lot of potential uses for genetics regarding blood glucose control, stratifying risk, preventing events, adverse drug reactions like angioedema, cough, bradycardia, allergic reactions, and also the pharmacokinetics of antihypertensives. And one can't deal with that all in one lecture. So I'm going to focus on a few aspects of the genetics of hypertension. Maybe we go back to the old hypothesis of genetic articles of hypertension, where Platt said it's a low frequency dominant genes, and I know that there's low frequency dominant genes called hypertension, and these to inheritance of major genes leading to hypertension, and Pickering, the high frequency smaller genes in this area that are transmitted to the offspring. So the kind of polygenetic hypothesis, and that has been the sort of dominant hypothesis. But in fact, it turns out probably both are correct, as we know. Now, when we look at hypertension according to age, we also see that monogenic disorders, although we should be focusing them on in the young, they can still occur throughout life and should be considered. Now we need to, obviously in children and adolescents, focus on these disorders. And this is the approach I said when you're seeing a young hypertensive. And there's no obvious cause like underlying chronic kidney disease and mid-aortic syndrome and so on. There's renal salt dependent disorders or renal salt independence, and we'll go back to the renin again, and these will be low renin states, and these will be normal to high renin. And these will maybe phosphodiesterase mutations leading to hypertension brachydactyly, or hereditary syndromes related to pheochromocytoma and paraganglioma. The low renin disorders then are defined by low renin normal aldosterone, Gorda syndrome, high potassium, little syndrome we spoke about, syndrome of apparent mineralocortics, and congenital adrenal hyperplasia, and the Geller syndrome, which is a change in the mineralocortical receptor that responds now to progesterone. And the high aldosterone is basically familial hyperaldosteronism. And there are 4 types. I'll talk to you about one type in this talk. So these are specifically the types, and the familial hyperaldosteronism, low and high renin, and the treatment of this one is corticosteroids, and I'll come back to that. And then mineralocorticoid corticoid antagonists, Gordon syndrome, which is in the overactivity of the sodium channel in the distal condylar tubule with hypertension, increased potassium, metabolic acidosis, and you treat with a thiazide, which is a specific blocker. And then the little syndrome we've spoken about, amyloid, syndrome of apparent mineralocortical excess, where you change in the 11-beta-2, which breaks down cortisol to protect the aldosterone receptor from cortisol, and you treat that with a mineralocortical, and then the Geller syndrome, which you need to stop progesterone or deliver the fetus, which is a mutation in the mineralocortical receptor and responds to progesterone. And these are the ones with high renin, paraganglioma, and the brachydactyly syndrome. And this you treat with alpha blockers and surgery if you can, or combination antihypertensive therapy. Just coming back to familial hyperaldosteronism, there's a crossover in these two 11-beta-2 and 11-beta-1 that regulates aldosterone, that regulates cortisol. There's unequal crossover chimeric gene now responds to cortisol, which is 1,000 times more higher than aldosterone production, resulting in excessive production of aldosterone by ACTH. And you get low potassium and excess aldosterone. And treatment with this low dose cortisol to protect ACTH. That's your best treatment. And then the little syndrome we discussed, mutations in the amyloid sensitive epithelial sodium channel, a simple Mendelian inheritance. And this what's happened is ENaCs are modified and NED42 cannot break down them, so you get excess representation on the surface of the cell and greater activity of the ENaC. And NED42 is also linked to hypertension if it doesn't break down this channel. As I've said, we found this very common in South African population. And in Chinese population, if you have low renin and low 1.72% of patients have liver syndrome. And the specific treatment is obviously amiloride. The other genetic associations with treatment responses, like thiazide, NED4L, beta blocker, adrenal receptor, metoprolol, one of the cytochromes that metabolizes, and verapamil, losartan. But these really not very clinically useful in big studies. So what about, going on, leaving aside these specific aspects of monogenic disorders? This was the first meta-analysis done on hypertension. And it's a genome-wide association study with 29,000 patients. And they found 1 to 2% of identified risk, where we should have about 40 to 50%. So there's a lot of despair about that analysis. However, it's not all despair. And a lot of people said this will never clarify genetic architecture, identify causal genetics, and no surprising new mechanism, new targets, and any clinical useful method to treat hypertension. And of course, it is a guideline says, as it said, genetic testing should be for monogenic disorders in highly specialized clinics like clinics that you run. However, the newer genome-wide studies have now extended to involve over 1 million people involved in these studies, huge numbers. And you can see the great identification of the rare variants in red, and now they've discovered common loci with replication and additional common loci. So there's a huge increase in the number of potential sites. And this is the effect. You can see it's polygenic, small effects on systolic and diastolic blood pressure, but you can see there are some genes that have large effects on blood pressure and having a kind of dominant effect. And in this, they've identified 130 new novel loci that are associated with hypertension. So this is very important to discover new loci in this complex disorder. And what they've now done, looking at these low loci, look at how they function, how the proteomics and so on. They could also look at their relationship with the subphenotypes of hypertension. This is another very important aspect of hypertension, how some of these genes interact with salt sensitivity, obesity, primary aldosterone. And we also can enrich for rare variants and understand diseases that cause dominant forms of hypertension and more severe target organ damage. And also, the other thing is you can look at a UK biobank taking these genetic associations from that big meta-analysis by GWAS by Evangelo from the UK biobank, and look at a Mendelian randomization analysis on association with outcomes. And what they showed is that, as expected, both systolic and diastolic disease was associated with all the known issues we relate in hypertension, from stroke, cardiovascular disease, heart failure, transient ischemic attack, both systolic and diastolic. So these are, if you look at this, which you translate in what you call polygenic risk scores, And you can classify people into low risk, intermediate risk, normal risk, and high risk. And you can see the development of hypertension in future is much greater. So it can lead to targeting of particularly of children, and I'll come back to that, to actually intervene much earlier in the pathogenesis of this hypertension. Does it go across ethnic groups? It does indeed. So in Africans, Asians, and whites, the associations with polygenic risk scores were all the same, very similar. So this is a very good standard to look at. And if you look at this, have been an ABCD study, the large GWAS, they looked at 29 S&Ps associated with increased risk of hypertension, and they showed that these things, again, was linked to risk of hypertension. So they looked at the risk of hypertension, and they ranged their scores from 0 to 58, and less than 28 was low risk. And they looked at the effects of DASH diet, studying these groups of children. And you can see that the DASH diet and genetic predisposition was both associated with blood pressure in children 5 to 7. Gene-environment interactions were found between adherence to the DASH diet and GRs on blood pressure. And children with a high GRs genetic risk score developed blood pressure, and they have a greater benefit from having a specific health diet, DASH diet, compared with children of low risk. So we can look at this and establish genetic risk scores. You can have low risk, and then you can have high risk. And obviously the high risk, we want genetic and early intervention, particularly if they got bad lifestyle. Obviously children, even if they have low risk, have bad lifestyle, still need early intervention. But these children at low risk would have standard intervention. So this is an important group, and the children in yellow would then have a standard intervention. And of course this field has grown enormously, and this is the development of antihypertensive. Huge number of identification of now genes associated with hypertension has grown exponentially, and S&Ps have grown to over 2,000 associated with hypertension and GWAS. So it's an important and exciting field. How it's going to implicate practice specifically in antihypertensive therapy is still to be determined, and this is omic sequencing, deep phenotyping, genetic risk scores, improved risk stratification, pharmacogenomics, personalized medicine, Mendelian randomization to identify novel biomarkers, and pathway analysis to develop target antihypertensive therapy. Just one word on pharmacokinetics. We've recently looked at amyloidopene metabolism, and amyloidopene is metabolized by these cytochromes, 3A5, and we looked at the outcome related to S&Ps in this cytochrome, and certain genetics associated with resistant hypertension, and some had non-resistant hypertension. And basically this change, this RS change, leads to increased expression and clearance of amyloidopene. That's our theory. And this gene led to reduce the clearance of amyloidopene and increased levels and better control of blood pressure. So this is another aspect which I just allude to, is the pharmacokinetics of antihypertensive imperative and the drug interaction between drugs that influence cytokines. And so when we go back to our diagram, perhaps in future we'll do a study of the genetic risks and make them high risk, low risk, and make some kind of formula and add in all the other aspects we talked about, and then come up with early birth prediction, early assessment, diagnostic support, treatment guidance, and prognosis. And this perhaps will change therapy in the future. So there's greater understanding of genetic architecture of hypertension interaction with environment, both rare and common estimate linked to pathogenesis. I won't go into that, but certainly linked to low blood pressure as well. Mendelian randomization confirms strong association with the usual adverse outcome. Genetic risk scores predict hypertension adverse outcomes. Epigenetics predicts hypertension onset. I didn't go into that, but that also shows association. And performing genetic risk scoring in children may provide significant advantage by targeting children at risk for bad outcomes. And maybe the road to precision medicine may be closer than you think. Thank you very much for your attention.
Thank you very much for giving more insight in this rapidly developing field. So I think it will be very interesting to see in the future what precision medicine will bring.
Yeah, I agree with that. But I think it's happening, and we're going to be able to target more therapies, I think, in the future.
I have a question and then a comment if there's time. And that is, given the advancements in GWAS and in finding variants that may be of interest, do you think, since most of us in the room are pediatric hypertension specialists, should we be getting genotypes or the like in our patients and keeping the sample afterwards because more and more is being known? Will that help us be more effective? Will that lead to personalized medicine?
I think if you can cover a number of genotypes that have been developed from particularly the dominant genotype, because they're extending those, and if you can actually have I forget what the name of it, you do all the genotypes in one go. You understand what I mean? You target those genes and you target the genetic risk score. That would be, and I think these need to be developed and put into clinical practice. And storing samples is always fantastic. I think I would agree with that for looking for the future.
And the other thing is a comment that I'd like your opinion on. You said that type 1 hyperaldosteronism or glucocorticoid responsive aldosteronism, GRA, should be treated with glucocorticoids. And I think in some parts of the world that's used as a test but not used clinically because of the experience, at least in the US, that children treated with glucocorticoids with that diagnosis often have adverse effects from the glucocorticoids, and diuretics work quite well, like spironolactone.
Yeah, and spironolactone also has a lot of side effects too. So maybe we have better aldosterone antagonists. But I think you've got to use physiological doses of glucocorticoids, not pharmacological. So I think it depends what the outcome you have with your children when you treat them. But certainly this would be the kind of specific treatment to suppress it. And maybe we should be using hydrocortisone rather than prednisone, which is a bit of a blunt instrument, in my view, regarding treating it.
Brian, question. Do you think that artificial intelligence will help us or not in precise medicine, how we treat children?
Oh.
I think this undoubtedly should, and the way to use artificial intelligence, not just take a question to the internet, is to collect all the major studies that are scientifically sound and put that into a database and then get AI to analyze that. I think that you've got to use AI with intelligence. You can't just use AI. Just throw out the talk, because that's what I do when I give a talk. I put into AI the title of my talk, and it's amazing what garbage I get. So, but if I put into my talk all the really good articles on the subject, and then get AI to make my talk, that could be really amazing.
Yeah, my concern is
prepare a talk in 10 minutes with the slides.
That's exactly my concern. There's a lot of parents and, you know, they just use it and then they come to you and say, that's what I read, okay? So
Yeah, no,
we
it's,
really have to emphasize.
AI it's actually, I think we shouldn't use AI, you should use machine learning. It's an extremely powerful tool, but it depends what you put in the machine. And you've got to use your nut to decide what goes into the machine. And we may have biases too. Yes.
Teresa Šuláková, Ostrava, Czech Republic. I would like to know if it's possible that this high clearance for amlodipine, this genetically dependent high clearance of amlodipine, is possible to overcome, for example, with 2 doses or 3 doses of this medication, because there is high clearance.
Yeah, I think we measure amlodipine in our clinic now. One, it's a fantastic drug for adherence testing. With amlodipine, it has a huge volume of distribution, so you can't get rid of it or get your level therapeutic a few days before clinic. Okay, so it can tell you about long-term adherence, complete lack of adherence, or partial adherence. But we maybe should be looking at it in regard, and this is just new work out that we've done, showing, and we really need to look at the genes and then to the actual amlodipine level and if it's influencing outcome. I think drug metabolism is really important. I know personally, I take extremely low dose of amlodipine. If I take a high dose, I go hypotensive completely, and I wonder if I've got one of these genes that's swaying my metabolism. And the effects of edema formation and those sort of things.
Okay. Are there any more questions? Then, thank you very much. And thank you very much again to all speakers and to the audience for the discussion. And I think we have now 45 minutes for lunch break, and we will start at 3:45 in time. Is that okay? Okay. So, thank
No, it wasn't. It was down to 0. I don't know. It's an old phone. It's never done that before. So. They didn't talk very much.
Hi Adriana, how are you?
I am very so thank you for inviting. I can't believe it, and I'm also grateful to give the information for studying and give this opportunity. Thank you very much. Do you like it?